views. So I'll just share some of my views for how to economize the ECMO and whether ECMO is India needs ECMO. And we talk about a lot of resource limited countries and that. But what will the future of ECMO in India? That is what I'm going to discuss during meet. As I said, I always strongly feel that the technology should meet the need of the patient and the country. If it doesn't fit into it, then that technology of no use to us. So that is what we think, and we need to make it like that. Okay. So I told you I will be discussing on the scope of ECMO in India. So what are the hurdles, how we develop our programs, and what makes ECMO costly and how to control the cost. Okay. So if you see the different statistics, unfortunately we don't have a statistics which is prevalent to different diseases in India, because we don't get an exact situation. But if you extrapolate few data from the country, and depending on your populations, if you extrapolate the data, we have a huge number of patients who have requires an ARDS who requires an ECMO. Okay, so the incidence of ARDS which will require is going to be a huge number. Almost around 2 lakhs individuals gets affected, and out of that 74,500 patients dies in US. That's the strategy. That's the statistics in US. And if you extrapolate the same statistics in Indian scenario, even in that scenario, even we require almost around 0.1 million of people who needs an ECMO per year in Indian scenario. Even the 10% of the patients who have a severe ARDS, and definitely our statistics wise, the number of patients requires ECMO is much more, because we have does not have that good and in fact to control state this. Similarly, there are some data of sudden cardiac arrest in people, and there are almost 5 to 6 people who are dying because of sudden cardiac death. And most of this sudden cardiac death, if you see, that is the statistics in India in 2012 and 14 it was published. If you see that number, okay, then there's a huge number where this patient can be saved with the help of ECMO. So out of this, very few of them require CPR, so that's still a thing which needs to be improved. So we need to improve the number of the patient who we given CPR during cardiac arrest, whether in hospital or out of hospital or cardiac arrest. And if you see out of this cardiac arrest, the patients who died, some of them, at least 35% of the deaths are preventable deaths. So that is some acute event which has triggered it, and if you take care of that acute event, you can save a few lives because of that. So if you see the ECMO runs, and depending on the mortality and severity in different studies, okay, I have extrapolated data from US data and Germany data, and extrapolating it to the Indian status. See, we require almost, as I told you, around 1 lakh of people requires ECMO for ARDS. Similarly, around 2 lakhs of patients who requires ECMO for cardiogenic shock in India, and a lot of poisoning. There are 2.6 lakhs of death per year because of poisoning, and some of this poisoning definitely can be helped with the help of an ECMO. Initially in 2000, before 2013, we used to think that Cellforce has a nearly 100% mortality, but then after use of ECMO and Cellforce, this mortality has come down to less than 30%. So that difference it has definitely made. So again, and ECPR, as I told you. So if you see, we have a potential where we can do almost 5 lakhs cases per year, but hardly we are able to do less than 5,000 cases per year. So that's a huge scope India has when if you think about the number of ECMOs patients required. Now, what are the hurdles in using ECMO? One is availability of machine and the trained manpower, that becomes an issue. Second is in cost, because the cost is going to be an issue. When we keep on talking about cost, I do have some difference of opinion, but cost is an issue. Scientific validity. See, there are still some of the people, they don't believe that ECMO is going to work, because some of the study is not clearly defined. Now, for an example, Eolia study, or if you say ACLS shock trial, they are not clearly defined that ECMO is better than just managing a regular ventilator. The reason is they said that it should be used as a last resource. So still, because of there are no enough studies, and in fact none of the randomized control trial is been done in a proper way to prove this. and there is a limitations in that, and the awareness. Okay. Now I think the awareness part is definitely improved as compared to what it was before. Okay. So when I done a study in 2023 in Indian scenarios, 83 centers all over India has participated in this scenario, and all together from these centers, almost around 3,000 patients, they said that they refuse the patients for ECMO, even if it's indicated because of the cost issues. So that is the figure which I got it from the survey which I done in 2023. Okay. But if you see the Indian economy, okay, and Indian India in the right from 85 to the way it is progressing now, even there are 7% or 3% of the patients who are rich, and at least 30% are in upper middle class. All of them can definitely afford an ECMO, and that's a huge number if you translate into a number. Okay. And that is equivalent to the population of some of the countries. So if you see, because of our the huge population, there's a huge scope where we can think about putting this patient on ECMO, and we can have a lot of patients on ECMO. Okay. The cost issue, we think the ECMO is costly. If you see, if you make your own cost circuit, as I told you, you can make it in 1 to 1.5 lakhs, okay, depending on which type of oxygenator, which type of pump you are using. So, but you can easily make it your own circuit in 1.4 lakh. But what makes it costly is because if you are taking a customized circuit, okay, they don't sell you less than 2.5 lakhs to 4 lakhs. So that adds into the cost, okay. Usually all circuit works well for 10 days, okay. Okay, whichever the circuit you use, usually they work well for 8 to 10 days, and then only you might require to change some of the components. Many a times we have seen the circuit works well for even a month also. And when you need to change the circuit, that makes it costly, because if you need to change the pump, it might just cost you 20,000, but if you change the entire circuit, it will cost you 2.5 lakhs. So again, that makes it a cost. It adds into the cost. So again, whether change of circuit or change of components, that becomes an argument. Unfortunately, the company does not provide you the entire different components, and that's why you are forced to change the circuit. So that's the way it makes it costly. At the end of 10 days, 15 days, if you ask again related to that you need to change the circuit, that will cost you around 2.5 lakhs. Then you are not sure of outcome. Then makes it a patient to think about how they can manage. If the recurring cost of ECMO running cost is hardly anything, in fact, if you see, that will be not more than 2,000 to 3,000, and that will basically on the monitoring the ACT and blood products what is required. So that will not be on an average more than 2,000 to 3,000 per day. Okay. So if you think about the cost of making a setup, the ECMO machine is not that costly. It's around 40 lakhs to 60 lakhs. Probably might have increased a bit nowadays, but still remain in that range. If you require a trained manpower, most of the times you can manage with your ICU nursing staff. If you train them well, you don't require a separate, and that is what I am intending, that we should think about developing our own ICU staff who can manage the patients on ECMO. So that is not an extra burden on that. Because the ECMO cases are not constant, people don't like to keep the ECMO staff per se. That is the issue. As I told you, the cost of investigation because of ECMO and that is going to be less than 3,000. Okay, these things can be easily managed with the help of you can have a large volume centers. If you have large volume centers, definitely the cost is going to come down. So if you have more number of cases, the volume scenario is going to change this. So if you see on an average ECMO run in Indian scenario, it ranges from 5 to 6 lakhs per day of the entire cost. Okay. So cost issue, what it makes it costly is initiation cost, okay, maintenance cost, especially if you need to change it, and on top of it, the additional ICU cost, the antibiotics cost, and other medications. So that makes it costly. And on top of it, if you require some other interventions like CRRT, then that adds into the cost. So ECMO per se is not that costly, but then if you count everything on that, then it makes it more costly. Okay. and the investigations and the multiple referrals. Okay. This is what the billing difference I have analyzed from our centers. In fact, we are very conservative in investigating the patients. We don't investigate very much to the patient. And in that scenario, the initiation cost was only around 8 to 10% of the total billing. Okay. Maintenance cost was 16%. Most of the billing was from pharmacy, which was more than 50%. Okay. So your cost increases because of your use of higher antibiotics, antifungals, and that makes it more costly. Okay. So when we thought about initiating ECMO in 2006, when we have Dr. Goel been to US, and he thought that looking at the meticulousness and the investigation every hourly, different staffs and everything, we thought that ECMO is not there for Indian trainers, because the cost is involving in that is huge cost that is involved. But then I've been to 2010 in Taiwan. The scenario was completely changed. The Taiwan economy is almost nearly to the Indian economy, and they are very conservative in investigating the patient. They used to manage the patient with Medtronic pumps. Okay. So the cost, they used to have a large volume centers, and they used to do, SCT or ABG once a day, or even on alternate day, ACT only twice a day. So they have a different model where they used to do, and then they are quite successful because they have a huge number of cases. They do almost around 180 cases per year, and that was a National Taiwan University Hospital. So that they have a huge volume, and they can easily done it with a lower economy, and that made ECMO as a public program, and ECMO has been offered free to the population. So that has changed our vision that yes, you can still do ECMO with if you have proper manpower. So there in their scenario, they have to have a nursing staff who is managing everything, and for 3 to 4 patients on ECMO, they have one perfusionist, so who can take care of the circuit if at all required on a duty. So and they have a large volume. So I said they when I've been to there, they have 5 to 6 patients on ECMO during that time. So for that 5 to 6 patients, they have required only one perfusionist to take care of circuit if there's a problem. Most of the time, otherwise the nursing staff has to manage it. Okay. And as I told you, they used to restrict the investigation, and they used to make their own circuits. So what makes it costly? If you just think about this, as I said again, it's my view, personal views. Number one is prolonged ECMO. Okay, that makes it very costly. So, and that is why, because you are delayed initiation. So if you start ECMO late, okay, ECMO is going to be there for a longer time, and when it goes for a long time, then if you see that the antibiotic cost and everything keeps on adding, and that makes it costly. Second, the maintenance cost, the investigations and referrals, and that is what probably the corporate cultures. If you do every 4 hourly ABG, that is going to add into the cost. If you have multiple referrals, that is again going to add into the cost. And the maintenance charges. If you see the charges which has been maintenance charges for ECMO per day, that ranges from 25,000 to 50,000. Even places there are 75,000 per day for the ECMO charges, just for a maintenance of ECMO charges. Probably that makes it more costly in that. Plus, when you have an additional complications like you require an additional support for CRRT or antibiotic cost, that makes it. And third, and the last thing is our thought process, the knowledge, the fear, and marketing strategy. Okay. Why I'm saying this for this is the reason is for that we try to make ECMO as a hype and a high-end therapy. It is, I don't say it is not an high-end therapy, but because of that, what has happened is, for an example, you can do ECMO with a Medtronic machine also, and you can do ECMO with cardio help also. Okay. So cardio help people will say that it's very easy, you just take it and go. See, I'm not against any of the companies, but I'm just giving you an example. The cost of that circuit is 2.5 to 4 lakhs. Okay. Do we actually required that for all the patients? It makes the transport easy, everything they will tell you, and you go for it. And there are centers which I know who has taken that machine, and after that they are repenting that they have taken that machine and they cannot offer to the patient because the cost of the circuit itself is around 2.5 to 4 lakhs. So that is what, when you are purchasing the machine, you should think that whether the disposables are going to be helpful to you, or you are able to take that disposables. Once you have taken that machine, you cannot take a disposable from anything else, because your pump is not going to fit there. So that makes things more costly. Second thing, we just think about investigating patients more and more. I agree that there is a risk of medical legal case and that, but again, that fear makes us to put more investigation. More you investigate, the cost is going to get added into that. So the initiation cost, you can, if you make your own cost circuits, you can definitely get the cost down. Or if we have something like a Make in India program where we can get the cost down, if you have the machines, the circuits, everything is made in India, probably the cost is going to come down. But the hurdles in that is you don't get a separate pump, as I told you, so that becomes an hurdles if you want to do your own circuit also. Even if you want to do it, they will not provide you separate pump, they will not provide you separate oxygenator, so that is going to be an issue. And Make in India program, we tried since years for Make in India program, but that has not worked. The reason is that people used to think this is not a huge volume, and if there is no large volume, then nobody is interested in doing going into manufacturing, because that involves a lot of cost for that. And for that you require some people who are really interested, where they are not looking into as a ECMO as a business. Probably they might be able to do it, because then there is no that big profit margin in that. Okay, how to take care of maintenance cost? By early initiation. Definitely, if you initiate early, the outcome is going to be better. Short ECMO run, and then other costs can be taken care of. Large volume centers, if you are doing a large volume, then definitely your most of the maintenance costs can be taken care of because of that. Increased number of centers, if you have more centers doing that, probably that might be again it help in the competition, and then probably that competitiveness can decrease the cost of ECMO, maintenance cost of ECMO, which has been charged anything between 25,000 to 75,000 in most of the hospitals. And if we can develop some ECMO program in some of the government institute, then definitely or ECSH, ECIS or CGHS, then definitely the cost can come down. If you have patients who is not affording, patient is on ventilator, you have an option that you can shift him to a trust place or government place, but that option is okay. But that option is not there for a ECMO patient. So if you have some option like that, you can think of shifting these patients. And the management cost, minimizing the investigation, minimizing the referrals, and judicious use of antibiotics, probably that will decrease the cost. Okay. So ECMO in a resource limited countries, yes, if you have a careful selection of the patients, definitely it can help to come down on the cost, and careful selection of the circuits. Okay, suppose patient requires short run of ECMO, probably we might be able to do it only for a polypropylene oxygenator. Okay, that is what the cost can come down on that way. Make in India program, think of technology to be used and not the machine. So that is most important. Is you want to go by centrifugal pump and PMP oxygenator. Now, which company it is, that probably may not make a much of a difference. There might be some mild difference, but that must not going to be the big difference in that. So again, you have to categorize the ECMO per class. Early initiation, judicious use of antibiotics, increased number of ECMO centers, ECMO availability in trust and government hospital, huge ECMO training programs, so most of the people get trained in ECMO, minimizing the complications, minimizing the transfusion, and training the financial management for the ICU and ECMO intensives. Probably that will help in getting the cost down. Okay. So I always feel that you have to think about the necessity, comfort, and luxury. To me, the Medtronic machine is a necessity. That's a basic thing which you require. I agree that it has increased risk of hemolysis, but that is the basic necessity. Mackey and Sorin machine is going to be definitely a comfort for us, because the hemolysis risk is going to be come down, and you can use it for a circuit can be used for a long time. And if you go for a CentriMag and cardio help machine, it's going to be more of luxury. So you have to decide whether you want to go for a necessity or you want to go for a luxury. In that way, same way, investigation also, you might able to just manage, anticoagulants with an SCT and APTT, but then you can add NT10A, you can add TAG, you can keep on increasing the number of investigations, but then that probably might become more of a luxury rather than a necessity. You have to decide whether you want to go for necessity or luxury. And the more, if the way you go from necessity to luxury, it's going to increase the cost. And there are no studies which has compared this, which shows that whether this is going to improve the outcome. I have not seen any study which says that whether you just monitor the patient with acidity and EPTT and you monitor the patient with anti-10A, is that is going to change your outcome. There are no papers which is suggesting that. So again, that is the cost. Suppose if I am able to save a patient with an ACT and APTT monitoring 40% my success rate, and if you monitor by anti-10A, the success rate is 60%. Just because to improve the outcome for 20%, should I left that 40% of the people which I can save? That becomes a question for me. Okay, I'll just quickly go through the panel discussion there. So as I told you, this is Medtronic pump which shows a lot of hemolysis, and this is what is my experience in 2017 when we published. We required 22% of the patients do require change of pump, but then change of pump is only 10,000. Okay, so 80% of the patients whom we managed, they didn't require the change of pump, even with the Medtronic machine. Mid-dose oxygenator, most of the time we have used it, and we just required to change it only 13% of the cases. So rest of the 77% of the cases doesn't require anything to be done. Okay, you can do ECMO transport like this. This is what we used to do it with the Medtronic machines. And you have to decide, you can do the cardio help like this, but the cost is huge difference. So I can make a Medtronic circuit 1.4 lakhs, cardio help circuit 3 to 4 lakhs. So I don't think there's a huge difference in managing the patients. Might be, as I told you, the difference in necessity versus the luxury. ECOR, I think Dipanjan is the best person to answer for that. If you take this ECOR system, that costs you 4 lakh circuits, and Dipanjan Arpan has done a lot of cases with that by just using the pediatric oxygenator and your regular dialysis machine. So again, that will cut down the cost. The issue is that for everything else, we talk about categorizing patient as per the class. We don't offer everything best. Most of the time we still get away with a CR slate rather than a CRRT in cases. But we are not thinking in terms of same thing in terms of ECMO. Okay. So this is what my view is. ECMO can be divided as per the class A, class B, class C. And then you have a huge patient who can be supported with that. I don't say you don't use a standard ECMO practice or high-line machines and that. Yes, you can use that, but that is only for those patients who can, for that affluent class who can afford that. And you can keep the ECMO running for a number of days, and you can bridge it to transplant or the bridge to destination for that patient of case. But those patients who cannot go for a bridge to transplant or bridge to destination, should we not offer them ECMO at all? I think no. You should think about that. You can use a middle way where you can use judicious investigations, private or corporate hospitals, middle level ECMO machines like Make and Sorin. Probably that might help. And those kind of patients who require probably a ECMO for a very short term, like a self-force poisoning. Even if I do self-force poisoning and manage them on Medtronic machine, I don't think it's going to make a difference, because that ECMO run is going to be 2 to 3 days. But just because we just think that ECMO is going to be a costly, we don't offer them and let all of them die, it's going to be difficult, So you can, this is purely my view, Ram. I said this to the beginning of the talks, but then it is purely my view. So you have to just value of life, this chance of survival, number of years added, and quality of life. That is the value versus cost analysis. You have to think about it. Okay. I strongly feel the best way where the ECMO can be done is in government hospital, because the cost is going to be limited. It is just the cost of disposables, that's it. Manpower, they have ample of manpower. Rest of the things are not being charged in government hospitals. So I'm just going to end my slides with that. We have to think that whether you want to save few lives just by maintaining minimum standards, or you just be idealistic and let people die without offering the treatment to us. That is basically, I think it should be categorized as per the classes, and make a common practice, ECMO as a common practice in ICU. I strongly feel that let the ECMO to be a part of an ICU, don't make it hype. All of us manage ventilator patients, all of we manage all sick patients, so let the ECMO to be like something like that, probably that will decrease the cost. So I strongly feel let us other things that make ECMO affordable for India rather than can ECMO India afford ECMO. Thank you.